initial assessment, was not able to move or feel anything. He was awake. He was arousable, kind of minimum sedation, but was not able, didn't respond to pain stimulus, to any kind of stimulus at all, wasn't able to feel me touching him. And that really prompted a pretty significant response. We took him down for a CAT scan. We did a head and neck, looked like something around his spine, and then he went emergently for MRI. And on the MRI, there was an abscess around the spinal cord. So essentially a septic hematoma had developed sometime during the critical illness, somehow from that severe infection and severe sepsis that he had. So he went emergently for a laminectomy, opened up, cleaning out that abscess around his spinal cord, but we were able to get him extubated the next day. He wasn't able to move anything. He had very minimal sensation, but wasn't able to move any of his extremities.
Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life. Welcome back to the Rapid Response Room podcast. I am so excited about my guest today. I have joining me Michelle Dedeo. She is a fellow critical care nurse educator, but Michelle's also a clinical nurse specialist whose expertise is in trauma and neurocritical care. Michelle, welcome to the podcast.
Thank you. What an honor. I'm so excited to join you. Thank you.
Oh, yes. This has been a long time coming. I'm super excited about this one. So today we're going to talk about a patient whose course of care did not go as expected. When Michelle told me about this patient she had cared for, I just had to have her share with you all because there's so much that we can learn from this case. Both the science of nursing and all of the nerdy patho behind spinal cord ischemia, and the heart of nursing and the important role that we play as patient advocates and in implementing evidence-based interventions to promote the best outcome for our patients. So I cannot wait for you to hear from Michelle because she is about to drop some major nursing knowledge and wisdom. This is going to be great. Before we dive into the case, though, I want you to know who Michelle is and the expertise that she's bringing to the podcast today. So Michelle, can we start with how long have you been a nurse? What types of nursing roles have you held? And what are you up to these days?
I started as a registered nurse in a trauma ICU at the University of Wisconsin in Madison. And I got my bachelor's there and started in trauma, and I loved it. I worked there for a number of years, and then I left and became a traveler. I mostly worked in trauma and neuro ICUs, and then did a little bit of wanting to expand my professional practice and worked in a cardiovascular surgery ICU and doing transplants for hearts and lungs. And I've done a ton of stuff. I stopped traveling in the late 2000s, 2008, 2009 in Seattle. And that's where I live now. And I went to grad school out here in Seattle and work at an organization. I'm currently a clinical nurse specialist. I finished my master's and my doctorate in 2014. And since then have been working in the CNS roles. I did a little bit of stint as nursing faculty for a bit, and it was an awesome opportunity to learn how to teach and to learn how to develop curriculum and to learn how to really pull it together, which was something I had never done. But my heart and love is in patient care and practice and advocating for nursing practice, being that clinical expert, being able to support nursing practice at the bedside. I really love the direct care practice of nursing. I love what we accomplish. I love our role. I love the impact that we have as nurses. I love that the majority of the time when you are a patient, once the kind of medical things have been fixed and either surgery has happened or the medication has been prescribed and you're on your antibiotic regimen or whatever's happening, the reason that you get better is because of the level of nursing care that you have and the quality of nursing care that you have. And I love that role and impact that we have. And so that means a ton to me. And I find that my role as a CNS and as an advanced practice nurse impacts the nurse's practice. I have a lot of knowledge and experience at the bedside. I love taking that and leveraging that to be able to work to minimize the barriers that they have. I love being able to make sure that they have the supplies that they need, the equipment that they need, the way that they document, like the processes, all of that stuff. And then also being able to connect with patients. So those are my favorite things. That's what I do now. And mostly focus in neuro currently, but I love trauma as well.
I love what you said about, the surgeon can do a great job, all that good stuff. But the reason patients get better is because of the quality of nursing care they get afterwards.
Yeah.
That is very powerful. And definitely like a responsibility that we have as nurses to really carry this patient towards recovery. So yes, that's why we use CNSs to promote that quality care after the intervention that's hopefully going to be helping this patient get better. Michelle, I love it. I can't wait to talk about this case. So let's dive in. Can you just kind of set the stage for us? What were you told in a report? And then what did you discover as you're doing your morning assessment for this patient?
It was a long time ago, but I was working in medical ICU. I was getting a report, and this patient had been really sick for a number of weeks. Come in initially with severe sepsis, intubated, paralyzed for a really prolonged period of time. And the plan for the day was for me to get them extubated. That was going to be the first kind of thing for the day. And this patient on my kind of initial assessment, I'd heard he'd been getting better. He had been on CRT for a prolonged period of time, had kind of gone into multisystem organ failure, ultimately in recovery, had major steps, but hospitalization had been a pretty long period of time. And on my, that was my report. I was anticipating being able to, he was coming off of sedation, getting off of sedation, waking him up and getting him extubated. That was kind of my goal for the day. It was pretty from the beginning. And on my initial assessment, was not able to move or feel anything. He was awake. He was arousable, kind of minimum sedation, but was not able, didn't respond to pain stimulus, to any kind of stimulus at all, wasn't able to feel me touching him. And that really prompted a pretty significant response, I would say. So contacted the providers, contacted the medical team, let them know what I was finding. They came in and assessed him. We took him down for a CAT scan. We did a head and neck, looked like something around his spine, and then he went emergently for MRI. And on the MRI, there was an abscess around the spinal cord. So essentially a septic hematoma had developed sometime during the critical illness, somehow from that severe infection and severe sepsis that he had. A lot of the impact had come into an epidural abscess, and an epidural abscess had formed. And the amount of time or when it might have happened, not super clear based on the documentation and assessment. He'd also been sedated and paralyzed for a long time. So, it's unclear timeline of onset and things like that, what that looked like. So he went emergently for a laminectomy, opened up, cleaning out that abscess around his spinal cord. And then I had him for kind of a long stretch. I remember it being about 5 days in that amount of time, but we were able to get him extubated the next day. And he wasn't able to move anything. He had very minimal sensation in any of his extremities, but wasn't able to move any of his extremities. So he really kind of started from there progressing with mobility and concerns and assessment and workup from that standpoint.
My goodness. So just to review, this patient came in for something totally unrelated to his spine, just sepsis, and obviously critically ill. If he was on CRT, that's continuous dialysis. He was on the ventilator. Like, this is a sick patient. But if it's extubation day, that means they're getting better, right? They're supposed to be awake and alert and off sedation before we're pulling this tube out. So I just have a question. How long had he been off sedation whenever you went to do your assessment and discovered this, oh my gosh, he's not moving or responding with his extremities?
It had been weaned down kind of over time. He was on still a little bit when I was taking care of him, some benzos, small dose, but, he had been on a very high dose for his amount of stay. And I would say this was a number of years ago. So we've, done so much work in the last even 10 years working to be able to address some of our sedation needs, our ICU liberation work. But so he was on a little bit, plan was to turn it off. He was following commands. He was nodding. He did wake up, but he couldn't move anything or feel anything. And I would say, based on the report that I had gotten, I don't know that had really kind of come in to full concern or awareness previously. And when I think about him, it's the piece of, do we take it for granted that prolonged ICU weakness that can develop with severe prolonged sedation and, neuromuscular blockade? Or is there something else that we could have looked at, in a deeper way from a workup standpoint to be able to consider some of his neurologic impairments?
Yeah. So from your experience, why do you think this patient developed spinal cord ischemia? Like, what happened?
I think he ended up having, when we think about ischemia towards the spinal cord, we kind of think about what is the cause of what happened to generally impair perfusion. So you can have a spinal cord injury that's traumatic. Many of us think about that from a nursing standpoint in those terms. We understand the injury that can happen related to a traumatic injury, shearing, tearing, penetrating wounds, things like that. You can also think about it as impaired perfusion. So because of the vasculature and how blood flow comes to the spinal cord from like the aorta and off of the subclavian artery. And, with aortic dissections, blood flow to the spinal cord can be impaired as well in that situation. There's also some pathology that can happen with perfusion related to epidural abscesses, bleeds, hemorrhage, and things like that. So the kind of initial determination would be, did he have this abscess that developed and caused compression to the spinal cord so that we have impairments and issues to the nerves, to those motor nerves as they're functioning? And then from that, did ischemia develop based on compression? Because with that nerve compression, you can also have blood vessel compression based on where everything is at. So, what kind of came first, the chicken or the egg in that? It's really hard to tell. But his was related to that abscess that developed ultimately with that whole illness after that happened.
Gotcha. Can you take a couple minutes and just dive into like the pathophysiology of spinal cord ischemia? Like, what are the signs and symptoms? Diagnostic criteria, so we can be on the lookout for this in our patients. Even though it's rare, it's definitely a possibility.
Yeah, it is rare, but unfortunately, it's not, uncommon, especially with specific types of surgeries and specific injuries. I think it's really important to think about the risk of the injury as well as potentially the risk of ischemia. So the biggest signs that you would see, I talk a lot about code strokes and stroke alerts and things like that in my job as well. But I think the spinal cord issues kind of come in, we take for granted mobility. And I would say we've all been, in that position of, can they move everything? Oh yeah, they're wiggling their toes. But that actually doesn't tell us a lot about motor function. And so, some of the things about neuro that really scares people, of course, is it feels so overwhelming and it feels like a lot and it feels like it's very specific. But I have strong belief that if you can absolutely learn which areas of the heart and which blood vessel affecting the heart is infarcted, you can totally learn which area of the spinal cord is infarcted and what that would look like, right? Shows up on an EKG, it can show up on your neurologic assessment as well. So when we think about how they develop, the things that are the most important to assess for are the motor function. And then, your motor tracks of your arms, the motor tracks for your trunk, and then your sensory input, all of that sensory input track, they all run in different areas of the spine, which is probably really stressful when you're trying to learn it. We can all picture from nursing school that drawing of one vertebrae when you have all these circles and tracks all around the dorsal horn, the anterior parts of the spine, and like everywhere, everything's running. But I think the most important things to be able to think about are, what you're assessing for and what you're looking for. So I think as we think about as the blood flow, possibly in a spinal cord ischemia situation starts, the blood flow decreases. And as the blood flow decreases, you're going to see significant weakness. Now, if you have a patient who has a spinal cord injury, maybe traumatic, and ischemia, anoxia, impaired perfusion, or swelling or edema is developing around the spinal cord, it can happen in the spinal cord just like it does in the brain. So if you have a patient who already has a traumatic spinal cord injury and ischemia develops, you're going to see a worsening of the neurologic exam moving up. And so depending on what level their initial injury is at, that injury and that assessment, it's going to worsen moving up. So for example, I like to think about C3 to C5, keeps the diaphragm alive. Your hand is C6, C8, triceps T1, nipple line is T5, umbilicus is T10. Those are some of the big landmarks that are really good to hit. And so if you have sensation and motor above your nipple line, that's great. But one of the first things that you should be looking for is a developing weakness in the triceps and in your pinky finger. So if somebody's worsening assessment develops, their hand grasp is going to be a lot weaker. They might not be able to grasp fully, and you might see that weakness in that pinky finger, or they're not able to push against you in the same strength from their triceps muscles. So that's one of the first kind of assessments I think to think about. If your patient already has that injury, how can you assess well to look for what might be getting worse?
Can I pause you for a second, Michelle? Because I just learned something new from you. So my background is not in neuro. I worked in the cardiac ICU. However, all of those aortic surgery patients had spinal drains because we were worried about spinal cord ischemia. And the extent of my hourly assessment was, can you move your feet, move your toes? Can you squeeze my hands on both sides? Can you lift this leg? Can you lift this leg? Can you feel me touching your both sides? I mean, it was pretty basic. I checked the spinal drain. It never occurred to me to see if the pinky was moving just as well as the other fingers.
Yeah.
I would just have them squeeze my hands. I'm like, oh, feels good on both sides. I mean, I also never had a patient that had a poor outcome from an aortic surgery as far as her spine goes. But okay, so can you just review the whole pinky finger thing just one more time? Because I know there's lots of nurses that care for patients who are at risk of spinal cord ischemia because of an aortic surgery.
Yeah. And with the aorta, with aortic surgeries, it's challenging because generally, depending on where on the aorta, if it's ascending or high descending, right around the arch, depending on how much blood flow is impacted, the cross clamp time for surgical repair, and then blood flow to the left extremity. That's like, because the way the blood flow, of course, we all know the arch goes this way, blood flow goes this way, and then our spinal cord perfusion kind of comes off of that side. And that's at the level of about T5, which is super important to be able to know. So as you start to see in that situation, even one of the first things that you would see is a blood pressure variation and differential between the right and the left arm if you had impaired perfusion. But you are going to see a patient who has weakness. If they have spinal cord ischemia developing in that situation, they're going to have weakness of their lower extremities. And they might be able to wiggle their toes for kind of a long time, but your best absolute assessment is sensory input. Do they have sensation all the way up to about, T5? And from their toes, and can they lift their legs off the bed? That is going to give you so much assessment, because as that blood flow impairs, the perfusion to the spinal cord decreases, and the spinal cord needs as much perfusion as the brain does. And so we like to think about spinal cord perfusion pressures the same we do as ICP and CPP. And so maintaining a low pressure in that spinal cord space, and allowing a high enough spinal cord perfusion pressure, ultimately like that balance between ICP and CPP, also when we have a neurologic problem. And so as that perfusion decreases, ischemia starts and the risk for infarction develops. So as we decrease blood flow, the risk for anoxia in any central nervous system tissue increases, and that is where it would develop. And just because in that situation where you might see it first are around the levels below T5, so around the nipple line and down is where you're going to see a lot of weakness. Now that can be hard because we're not necessarily always asking people with spinal drains after aortic repair to get up and move their legs, to get up and walk around necessarily. And so it is important to be able to make sure they can lift their legs and that they can move their arms, because the first place you're going to start to see weakness, if that ischemia is spreading and is developing, is it's going to be moving up. A lot of time you'll see it down, you'll see it in the lower extremities, but you'll also see it as it can develop pretty fast, moving up in their extremities.
Hey guys, I'll get back to the show in just 1 second, but before I do, I have a request. If you have ever gotten any value from this podcast and you want the show to continue to grow, to access more awesome experts in the field, and to keep providing you with more nursing knowledge and inspiration, could you take a minute to leave a rating and a review? Those reviews on Apple and Spotify go a long way in getting this podcast in the hands of more nurses and bringing new guests to the show. And they just make my day to know that my stories and nerdy patho breakdown are helping other nurses thrive, or at least survive. So if you're feeling up to it, I'd love to see a rating and review from you. Thank you so much. Now back to the show.
And so the way I kind of describe that is, again, your C3 to C5 keeps the diaphragm alive. Kind of C6 and down to your thumb is C6, kind of C7 and C8 in this hand, and then T1 on the back of your arm. So as an injury moves up the spinal cord, it goes from T5 to T1 and your sensation loss and your motor loss worsens. Then you're going to get weaker in your ability to push. So pull is biceps, that would be C6, push is T1. And then a hand grasp is really strong, but this is all, again, like C8 to C6 right here. And so as somebody's hand grasp gets weaker, they're not going to be able to move their pinky in to make that full fist. Those are some of the first things that you would see to be able to know that their hand grasp is actually getting weaker, is they've lost that ability to move in or grab with their little finger as well. That would probably be one of the biggest first signs in that hand grasp and that fist.
That was actually really helpful. I wish you were around when I was getting my training on spinal drain. I mean, I remember like my orientation to CVIC, like, and here's the spinal drain. I was like, the what? I thought we're doing hearts here. The spinal drain. Yeah, but no one mentioned the pinky. And really, that was the extent of our assessment is, can they feel on both sides? And I would do sensation all the way up to their like groin, really. Can you move your feet? Can you lift this leg? Can you lift this leg? But they're not getting out of bed.
Yeah.
And I'm not checking bilateral blood pressures because they had an art line in. So we're just taking the blood pressure for its word on the one side of the body. So that clinical assessment is literally life-saving, knowing how to do it. So thank you for sharing those nuggets, pearls of wisdom.
Thank you for asking.
So as far as signs and symptoms, we talked about the sensation, the grasp and everything. Any other things you'd be looking for, just general patient population as far as spinal cord ischemia?
I think the motor and the sensory is the biggest opportunity. We should always question the ability to have a patient's ability to interpret their sensation. So I fully really assess their sensation. I can think of a patient a long time ago who had interpersonal violence and had been injured, really no anticipation of spinal cord issue, had concerns of foot surgery and a foot injury from that violence, but not initially thinking about spinal cord. And walking in, I started my assessment. They were intubated on the ventilator. Their eyes were closed. I had introduced myself to them earlier. I kind of walk in and start my assessment, right? I'm like feeling their feet. They're not responding. Normal person who's got their eyes closed and somebody touches them, we all know that pop their eyes open and they're like, what you doing? What's going on? And that was weird. And so I think that is, in that situation, that also drove a significant amount of work to be able to get full assessment and be able to get them down to CAT scan, to be able to look at what was going on as well. And then be able to wake your patient up and be able to ask them, can you feel me touching you? Can you feel that? And they'll tell you yes or no. They will be able to do that. So that full comprehensive assessment, both of the patient and of their sensation, is important. When we're thinking about the distal extremities, so your fingertips, your toes, when you're doing that kind of stimulus assessment, deep nail bed pressure, or seeing if they move, one of the challenges is those are lower motor neurons. So it's lower motor nerve function. So it's a peripheral nerve assessment. It's not a bad thing, but it will, a withdrawal sometimes or a triple flex reflex, those things can still remain intact even with a really severe spinal cord injury or spinal cord ischemia, because that motor nerve comes back to the spinal cord and synapses onto just really itself. And so you can get that sensory nerve comes back, synapses, and you can get a reflex response. But because possibly of a spinal cord injury issue, ischemia, it's not going to the brain for central nervous system assessment. So being able to think about also the difference between a peripheral nerve assessment and a central CNS, central nervous system assessment, is also really important. So what are those assessment features to be able to get that assessment comprehensively as well?
Gotcha. So you're saying a patient could have spinal cord ischemia, but still be able to move their toes a little bit or have a little move in his fingers.
Yeah, have a reflex, and it can be tricky.
All right. So as far as spinal cord ischemia, are there any diagnostic criteria, or how is the diagnosis officially made? I know you said your patient also went to MRI, but are there other things that kind of make up the differential diagnosis?
I think in the formal process of differential diagnosis, you have your clinical exam, and then we look for what's causing it. So ultimately, just like a lot of the central nervous system, the brain and things like that, you have to get an image because we have to see what's going on. MRI ultimately is one of the biggest opportunities to diagnosis because it gives you a really good picture based on time, which you can really estimate with time, which is why MRI is used so much in code strokes right now, especially on initial imaging. You can see and time out when the ischemia started. You can see the area of ischemia, you can see the area of infarct. And then on fluid attenuated imaging for almost everybody, you can see the development of edema, which times it out. Cerebral edema, spinal cord edema, all that stuff takes about 8 hours to develop once the initial area of infarct happens. And so that timeline is able to be really assessed by the radiologist as they're looking at the MRI. And so that's one of the big integral pieces of diagnosis, is being able to get the imaging to make that determination. That'll be important. Sometimes you might have providers want to look at EMGs if they're expecting it to be maybe a nerve injury or something related to motor neuron function, like with prolonged neuromuscular blockade, which will test for stimuli and motor nerve response in the periphery if you've had neuromuscular blockade for a prolonged period of time and those things. But the formal ability to make a diagnosis on the spinal cord is with an MRI and with imaging. And then depending on the time to onset, the severity of the ischemia versus infarct, you're going to be able to see if things can get better by trying to reduce the pressure in that space. And that's where lumbar drains, spinal drains, laminectomies, those sorts of things come in because they allow space to swell and they allow for space and recovery after an injury like that, no matter what the cause is.
Right. So as far as the severity of injury, is there like a staging that comes with spinal cord ischemia where we say like this one's really bad and this one's not so bad, or this one's recoverable, or this one's they're never going to have function back? How's the staging for that work?
The Spinal Cord Association has a staging of function based on post injury and based on your recovery. So it's graded A to F based on the severity of the functionality, how much function is lost and how severe it is. And so that's generally where the staging comes in, but it would be after the formal injury, after the time for recovery. Because one of the things with the nervous system is that we really can't prognosticate, at least for 72 hours and even up to weeks, because we have no idea what recovery will look like for you. And so it's kind of after that acute injury time when the classification for the level and the severity of the spinal cord injury that you sustained or a person has sustained is able to be determined with that classification and with that grading.
Gotcha. So when the family wants to know, are they going to get their function back? We can't say that until time has passed.
Yeah.
At what point would they be comfortable making a confident staging decision? Like how long after?
Generally you'll start to hear prognostication after about 72 hours to 96 hours. Medically, they start to get a little bit more comfortable estimating the severity and possible permanent loss, because that starts to be an important part of rehab. So once you have kind of the idea of what the permanent loss will be based on the severity, so that's after the recognition of the loss, of the motor loss or the injury or the issue, the procedure to try to correct it, surgery, a lumbar drain, whatever that is, and then kind of a recovery time after that. Then we give it generally about another 72 hours, 96 hours to start to be able to make a determination as to what that looks like and the severity of recovery will be. Because that plays, like I said, that plays a huge role into rehab and what your rehabilitation will look like. And even going into rehab with a severe injury doesn't mean that recovery is impossible. It just gives you, and recovery always looks different than what we sometimes hope it might look like. So how much, motor function is able to be gained, and the loss of severe or fine motor function, severe loss of fine motor function in your hands, that's a hard thing to get back, in recovery. But we do know that getting back strength and motor in some big muscle groups, like your biceps, like your shoulders, like your deltoids, like your triceps, like your neck muscles and things can happen. And so that can be significant for developing a plan for function and mobility moving forward for somebody.
So you had mentioned the treatment for your patient was a laminectomy. What are the other treatment options for this patient population? I'm sure it depends on the severity, but.
Yeah, it depends on the severity. In general, they had to do a laminectomy to wash out that abscess that had developed and clean everything out. That's generally if there's a hematoma or blood that develops in that space, they have to go back for some sort of procedure to be able to get into that area in the layers around the spinal cord, right? Our arachnoid layer, our dura, epidural, like all of that stuff to be able to get in and clean that out. And fix kind of whatever's going on there first. A lot of the time, there is opportunities for corticosteroids to be able to minimize the inflammation. So steroid treatment, dexamethasone, those sorts of things are really important to be able to help decrease swelling afterwards to try to minimize that edema that can develop and swelling that can happen. And then it's time. And then for some situations, it can be working to increase perfusion into that area. So anything that would be increasing the blood pressure, increasing perfusion, we know, and a lot of people are really, I think, more comfortable. Now we talk a lot about ICP and cerebral perfusion pressure, and we can increase a mean arterial pressure and blood pressure to maintain a cerebral perfusion pressure. That can be the same treatment in the spinal cord as well. So we might be working to, if we know what that spinal cord pressure is with the lumbar drain, working to increase the blood pressure, maintaining a specific perfusion pressure, and giving that tissue some time to recover.
Yeah. I will say, though, it was a frequent interaction between the neurologist and the cardiac surgeon as to what the ideal map was supposed to be. Cardiac surgery is like, I just put sutures in their aorta. We're not going to do a high map. And neurosurgery is like, no, we have to perfuse the brain. So which one's more important? I don't know. I'm sure they have different opinions, but that is definitely a challenge. Yeah. Being stuck in the middle as the bedside ICU nurse. Like, which map is the best one for this patient?
Yeah.
I know what's best for the aorta. I don't know what's best for the brain, but
1,000%. That is always the conversation, right? Like, we would never have a vascular surgery patient with a mean arterial pressure of 120. Like, to be able to maintain in general, but to be able to maintain a perfusion pressure, greater than 90, sometimes you do, which is just crazy. And so in the short term, not in the long term. So in the short term, we hope to give 24 or 48 hours, see if that perfusion improves. But definitely in the long term, that is not good for that patient. But yeah, that balance of the head and the heart is very hard.
The head and the heart, yes. The war between the head and the heart position.
Yeah, always.
So I have a hard question for you. Do you think that if this patient's paralysis or symptoms would have been recognized earlier, that it could have led to a better outcome for this patient?
I do. Yeah. If that had been, and it's so rare, right? And I totally know that, but if that had been really considered, maybe in the full assessment of the impairment to mobility, if that had been considered in the differential of full consideration as a risk even, are we sure after being this sick that they can move everything as we're getting ready? Then yeah, it could have been caught a lot earlier with surgery happening a lot earlier without prolonged impacts to mobility.
And I know that we've come a long ways when it comes to delirium prevention and treatment and the ABCDF bundle. I mean, even when I was working CVICU like 2011, 2012, it was just starting to come out, all of the expectations and the CAM-ICU score. I mean, all that was still somewhat new. I don't know what year you were caring for this patient, but it might not have been the norm to wake your patient up fully and do an assessment and then go back on sedation or just keep the sedation off. Can you just talk a little bit about I know this is not the podcast, but just because it's important, a little bit about the ABCDF bundle and how implementing it could have saved this patient or at least improved their outcome?
Yeah, I think it's important, right? So, the Society of Critical Care Medicine really started into bundling these interventions. We were looking at coordinated spontaneous awakening and breathing trials. We were looking at delirium assessment. We're looking at early mobility. We're looking at family engagement. And the Society of Critical Care Medicine worked to be able to build that into a bundle in 2017. And they really kind of formalized that, really get it together. A lot of organizations did so much work on bringing those together. This was, for me, this patient was before that. And being able to think about what that meant. We really started to acknowledge how significant the sedation and the prolonged sedation was on people's recovery, right? We know one of the biggest things is that sedated is not sleep. Your brain, when you're on sedation, is not sleeping. We all have, hopefully a lot of your listeners also listen to Kaylee Dayton, like her talks on the A to F bundle are amazing. She's such a great resource. She pulls the literature together really well, but we know that sedation is not sleep. And that's one of the most important things. And so the longer that you're on sedation and deep sedation, your brain is not actually going through those REM cycles. And so the ability to get delirious is super high. But we also know that doing interventions one at a time or by themselves is not necessarily tied to the best evidence to improve outcomes for patients, which is where that A to F bundle comes in. So when we think about it, we do have to assess pain frequently and often because uncontrolled pain is one of the biggest contributors to the development of delirium. So our ability to treat pain first is important. Coordinating our awakening trials and our breathing trials means that if we know they're going to go on an awakening trial at 6 a.m., I'm going to cut the sedation pretty much off, and we're going to be able to work to be able to physically get a breathing trial coordinated with that is going to make the success of the breathing trial much better. I think after COVID, I think we've lost some perspective, and a lot of practitioners, physicians, and organizations are kind of getting back to that recognition of what does it actually look like to wake up from sedation? If you're a nurse new to practice during the pandemic, I think it's hard to know, or it was hard to learn what it actually looked like to wake up from sedation. That was kind of a hard thing, right? It doesn't look like television. You turn somebody's sedation off. They've been really sick. They don't flutter their eyelids and look to their right and are like, oh, it's you. They don't do that. And so, they're scared. They're afraid. They don't know what's going on. Their brain's super confused. It doesn't know what's happening. It's had the lights on and doesn't know what time of day or where it's at or what's going on. And in general, if they're restrained, the human's first response is to fight against that, right? Like that's just it's what we would all do. That's just being a human being. And so I think thinking about that, knowing what it looks like to turn somebody's sedation off and give them time to start to clear that, give them time, be patient, lots of talking to them, you're okay, you're safe, you're here, you're in the hospital, you have a breathing tube in. They just, are hearing wah, 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 wah for kind of a while until that sedation fog kind of lifts. And then when we think about the choice of sedation, we recognize the importance of minimizing benzos. The use of benzos is so dangerous. We know it's important in a lot of things, but prolonged use of benzodiazepines it just increases the risk of delirium, prolonged cognitive dysfunction as well. We use it in a lot of things, but the less we can use it, the better. And so choice of sedation is really important. How can we find something that's maybe shorter acting, doesn't have the same impacts? And then, D is delirium assessment, doing those CAM ICUs, performing that full CAM ICU assessment is really important as we're looking at all of those pieces, recognizing that, to a RASS of -3, you can do an assessment. And I think when CAM was new, I was in a trauma ICU, and one of the clinical nurse specialists at the time said to me, I can remember that. Like I can remember just getting started using the CAM and having a really traumatically injured patient with spinal cord injury on a road arrest bed. And he was so hypodelirious and he was trying so hard to keep it together, not let me know that he was not okay, right? He was trying to hide it. And so as I asked those questions, his cognitive function was so high, he couldn't answer any questions right, but he was trying so hard. And it was one of the first signs I was able to go to the physician and say, he's CAM positive. I think this means we should stop with the Ativan. Could we try something else? Can we try a different type of sedation? And those are those biggest opportunities. The other time I was thinking about the clinical nurse specialist as well at the time who said to me, Michelle, if he can't follow commands, it's not that you can't do a CAM. If he can't follow commands, it's because he's delirious. Like, that's one of the most important things for us to think about. We're like going to go in and do our CAM ICU, and they're like, oh, I can't do it. He doesn't follow commands. Well, he doesn't follow commands because he's delirious. That's exactly why. And so that's an important way to be able to think about it. Not that I can't assess it, but instead he can't follow commands, so he's delirious. And that was like a light bulb moment for me. And then early mobility, and family engagement. We know families present, engaging, that makes a huge difference in having the patient recognize somebody's on their side, somebody's there to protect them. They have some sort of connection to who they are. And all of those things bundled together make the outcomes much better. And we minimize the likelihood of getting harmed in the hospital and in the ICU. We reduce your ICU days, reduce your ventilator days. That also leads to reduced device days, central lines and Foleys, pressure injuries, those sorts of things. So anything that we can do bundled together, those are our big opportunities to reduce the risk of harm to somebody.
Yeah, for sure. And if you think about those specific interventions, if those had been done prior to you taking over that patient's care, you probably would have caught that he's not moving his legs and he's not moving his arms much earlier.
And him knowing, right? It's that ask to, can you feel me? Can you move your arms? Because sometimes when somebody's laying there flat for a bunch of days, we just kind of take it, we lift their arms up, put a pillow underneath, and then we just kind of move on. But really being able to make sure that we make that connection for him as well.
Right. So thinking back about this case, are there any other pearls of wisdom or potential pitfalls you'd want nurses to avoid, or any takeaways that you would want for my audience to walk away with after hearing this case in this podcast episode?
Such a good question. I think one of the biggest things to think about is the importance of inter-rater reliability of a neurologic assessment. So doing it with somebody else and at handoff, having somebody asking the person you're getting handoff from at the bedside, show me what this looks like. Show me what it looks like and how you've been documenting it. That's so important. Taking the opportunity to be able to make sure that you know what has been there and what hasn't been there. And ask those questions. Ask that in your assessment. Ask that in yourself when you're doing an assessment. Did I see them move their extremities? Do they have a diagnosis where they should be moving all of their extremities? If you come in with a heart attack, if you come in with severe sepsis, if you come in with an infection, if you come in with pancreatitis or perfed bowel, you should be still moving your legs and your arms. There's no reason that they don't. Unless you, of course, have a reason prior in your history that you can't move them. But if you have not a lot of medical history and you came in moving them, you should still be able to move them throughout the entire stay. And so that's probably one of the first things, is knowing, where is this person's baseline? And I really need to be able to make the assumption there's no reason that they shouldn't be able to move them, and how we can do that assessment, starting with that expectation. The earlier we can make sure that they're moving everything and they're supposed to be, the earlier you're going to catch when it doesn't happen and when it's missing.
Amen, Michelle. This was fantastic. Thank you so much for sharing your expertise in this story with my audience. I know it's going to be so helpful in helping us be on the lookout and be vigilant and get that good assessment and be proactive in our care. This was so good. So I know my audience is going to want to hear more from you. So where can they find you, Michelle, if they want to hear more amazing education from Michelle?
Thank you. This has been so much fun. I've really appreciated it. I have a lot of opportunities. I'm really trying to build out a lot of resources for nurses and neuro. So I have a stroke review boot camp with Nicole Kupchak. That is a great course if you're new to neuro, if you need stroke CEs. It goes through all of the stroke processes, assessment, case studies. It's a really great resource. And you can check that out at Nicole Kupchak Consulting. I have an SCRN podcast and a CNRN prep podcast if they're getting ready to come out. The SCRN is out if you're getting ready to take the SCRN exam, stroke certification review course or stroke certification exam. Check out that podcast. It's easy to listen to, goes over all the content I do in my stroke certification review course. And the CNRN prep podcast will be the same. I have an SCRN practice exam as well. All of that's on michellededeo.com. I'm on Instagram at Michelle Dedeo, and the prep podcast is available on Apple Podcasts as well.
All right. Sounds good. And I'll put all the links to those in the show notes so it's easy for you to find.
It's been lovely.
Well, Michelle, thank you so much for your time today. I learned a lot from this actually as well. So thank you so much for sharing your expertise. It's been a pleasure having you. We may have to do this again.
I'd love to. It's been so great connecting with you. I've appreciated it a lot. Have a lovely day.
You too. Bye, Michelle.
Bye.
Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.